Hello. On behalf of CME Outfitters, I would like to welcome you to today's educational activity titled Versatility of Therapeutic Uses of Costimulation Blockade in Kidney Transplantation. This activity is supported by an educational grant from Bristol Myers Squibb. CME Outfitters is a joint accreditation provider and as such develops and certifies continuing education activities for the team by the team, including our program today. To receive CME or CE credit for this activity, scan the QR code to create an account. To ask a question, use the Q&A feature at the bottom of your screen. Joining us today is Dr. Flavio Vincenti, transplant nephrologist at the UCSF Medical Center and professor of clinical medicine at the University of California, San Francisco. Dr. Vincenti has shared the following disclosures. Dr. Vincenti will now share the 3 learning objectives for today's program.
So there are 3 objectives for today that I'll be discussing. The first one is to identify the optimal maintenance immunosuppressive regimen for individual renal transplant recipient based on available safety and efficacy data. Number 2 is to develop individualized management plan for patients who fail initial immunosuppressive therapy to sustain long-term survival. And the third one is to counsel patients with renal transplantation on long-term immunosuppressive therapy, emphasizing the balance between short and long-term goals. And so the first slide shows the struggles we have with the troubled kidneys that are not functioning or performing well. Allograft injury is frequently subclinical and later on becomes manifest. There are many likely causes for renal dysfunction and renal failure after transplantation. Many of them are immunologics, whether cellular rejection that are subclinical that lead to fibrosis or subclinical antibody-mediated rejection. There are some studies that shows that maybe 50% of patients who lose their graft may have some form of antibody-mediated injury. The nephrotoxicity of the CNI obviously is another feature that affects the kidney. And the vascular and glomerular diseases are also emerging long-term as an important cause of renal failure. There are only a limited number of cases in any given year at a single institution. So, this is where you need like big databases to look at the trends. The kidney biopsies are usually done for cause, and sometimes these occur late in the course when there is maybe too much fibrosis occurred. Now, there are some centers that perform protocol biopsies. Again, these are done maybe at 6 months or at 12 months. But this process is dynamic. It could be normal at 6 months, but a year and a half later, there is already some subclinical injury that is occurring. Now, one of the interesting studies, so-called the CAF trial, this was a multi-center trial. I think Bob Gaston and Art Matas were the main PIs. So in this multi-center trials, patients who had stable function, I think with a creatinine below 2, when they had a rising creatinine and a cause biopsy, what they found that the patients, not surprisingly, who had the best longer-term outcome after the biopsy, were those who were C4D negative on biopsy and did not have DSA. The worst patients in terms of outcomes were those who had C4D positivity and also DSA positive. And the in-between cases are those who had either only C4D positive with DSA negative, or they had the DSA positivity, but the biopsy did not show C4D positivity. So this next slide shows the summary of costimulation blockade in kidney transplantation. CNI-based regimens have served as the backbone of transplant immunosuppression for about 40 years. And these consist of currently tacrolimus, MPAs, plus or minus steroids. So although the CNI therapy secured exceptional short-term outcomes with low rejection rate, progress in long-term allograft survival has stagnated. So the attrition rate beyond 1 year, year after year, has changed very little. The nephrotoxicity and well-defined adverse metabolic effects of CNI have also driven a desire to explore alternative immunosuppressive agents. Costimulation blockade has emerged as a promising immunosuppression strategy, blocking a critical costimulatory pathways, the CD28, CD80, 86, and coming along now, the CD40, CD154, or CD40 ligand could substantially improve long-term survival. But there are many unmet needs associated with the use of costimulation blockade. This is a timeline, an interesting timeline of the summary of the development of costimulation blockade. I mean, if we start in the 2000, this is the first year when we started enrolling patients with belatacept in the phase 2, subsequently phase 3. 2011 was an important date. This is when the FDA and the European Regulatory Agency approved belatacept for prophylaxis for kidney transplantation. Then in the meantime, there were a bunch of drugs that were used but did not perform. Now, this is a combination of either the drug itself was not effective or poor design. It's a combination of both. I think of the most interesting ones that are still being looked at are, for example, the anti-CD28. So unlike belatacept, these block CD28 directly in a non-agonistic way. So this would be like lulizumab and FR104. FR104 is going to be moving in a phase 2 in the coming year. Blazalumab and iscalimab are anti-CD40 antibodies that were in phase 2 trials, but both failed. I mean, they failed, but at the same time, the designs were not the best. But anyway, there is no more clinical development with the anti-CD40. What became apparent from several experimental studies and was that the anti-CD40 ligand, although it's one pathway, CD40 ligand or CD154, but targeting the CD40 ligand it has, at least biologically, more efficacy than the CD40. That's because the ligand can bind to other ligands on CD8 cells. So now the concentration the focus has been on developing the anti-CD40 ligands. And here two are represented. One is dazodalibep. I will talk about it later on. Tegoprubart, a phase 2 trial, was just done in the past year. And there are actually two more anti-CD40 ligand that are going in clinical development. So I think we're going to be hearing a lot about these agents. So what are the unmet needs and challenges? With co-stimulation blockade, and now primarily with belatacept. One is that there is no standardized protocol for de novo use. The phase 3 regimen, I think, in real-life patients did not work as well. There are excellent results of clinical trials for conversion from CNI to belatacept after 6 months in patients with stable renal function, so that is pretty well set. However, quality conversion trials in patients with troubled kidneys are lacking, and that's what we actually need. For example, patients with DGF and other issues. But we also are discovering that belatacept and co-stimulation in general can play a very important role in desensitization. And I'll share with you a study that we're doing with the support of the Immune Tolerance Network. And there are special populations. For example, CMV mismatch patients are the good candidate for co-stimulation blockade, or highly sensitized patients. So there are many issues yet to be explored. So in terms of the of conversion, there are two randomized multicenter trial converting patients after 6 months in stable who have stable renal function, and those have been published. Our early conversion And that's where we actually have much more need. There are many single-centered studies, uncontrolled and monitored. So it's very hard to understand exactly how to use it, where to use it, what kind of regimen to use belatacept. You know, in discussing the two randomized trials that have been published with conversion after 6 months, and I'll show you the slide that's the data in a second. The problem is, in general, if patient is after 6 months doing well, stable, most transplant physicians don't want to convert or so-called rock the boat. Obviously, if the patient is having specific neurologic symptoms or some other issues, of course they can get converted. But I think the bigger need is how to rescue kidneys that are troubled. So this is the first study that was published by Rostag in AJT that was done. This was a sizable phase 2, about 80 to 90 patients in each group, where patients at 6 months who were on either tacrolimus or cyclosporin at that point were randomized to be converted or to stay on the same therapy. And as you can see, the patients who were converted right away within 3 months had an improvement in GFR. This persisted, the slope remained positive. And so at 2 years, these patients had an increase in GFR of 8.8 ml per minute. This is huge because, the attrition rate usually is around maybe just about under 2. So, if you extrapolate it, this is about 4 to 5 years extra of graft life. There was more rejection in the belatacept group, 6% in the first year, but actually the data after the second year, there were few more cases of CNI rejecting and none in belatacept. So this was a positive study, but this was followed by more recently published study in JASON in a much larger group of patients, over 220 in each group. Again, same basically protocol. And here the patients on CNI were all of them on tacrolimus. At 2 years, there was no significant difference in the overall patient graft survival. However, again, as we saw in the first study, within 3 months, there was a separation GFR, so that by 2 years, there was about 7 ml of GFR improvement in the patients on Bela as compared to those who stayed on tacrolimus. There was slightly more rejection in the Bela, 8% over 4%, all reversible. And again, something that we have noticed in the phase 3, and this is an advantage that has been recognized more and more, is that patients on belatacept do not develop the donor-specific antibody, 1% in those who were converted versus 7%. And when we did the phase 3 study, the benefit, and we saw also a significant reduction in DSA, we really did not appreciate the reason why, but now we know why, and then I'll show you a slide in terms of the mode of action of that. In terms of AEs or infectious complications, there were no difference between the two groups. So I think these two studies clearly cement the principle that if patients are stable after 6 months, and if you want to improve the GFR by certain and clinically relevant GFR, you can convert them, although there is a tiny increased risk of rejection, but these tend to be reversible. So the unmet need, as shown on the next slide, is the de novo use. What is the protocol that should be used? And I'll go through 3 scenarios that are being used. Nobody, and we shouldn't use the one that we published in the phase 3 benefit trial, because that doesn't work anymore when you use, all comers. The role of belatacept and conversion in DGF, efficacy in high-risk patients and patients with chronic antibody-mediated rejection. I think one of the problem we've had is that there hasn't been resources placed on predictive biomarkers. I mean, there are some that have been reported in research studies, but nothing that has been validated. And the question of using belatacept in desensitization, I think it's playing an important role, and I'll come to that later on. So this is a benefit trial. As you remember, these patients were randomized to either CNI or to regimen of belatacept, more intense and less intense. Only the less intense regimen was approved by the FDA because it was found to be safer and, in fact, more effective. There was more rejection in belatacept compared to the cyclosporin group. However, after 7 years, and this is for many years, is the first time that a new drug showed improvement of outcome compared to a CNI, cyclosporin. The GFR also, not surprisingly, over the 7 years, had a positive slope. There was a big difference and very clinically relevant difference between the belatacept and the cyclosporin group. And again, something that we noted in the study, and thankfully we actually collected data that patients on belatacept very rarely develop DSA, while cyclosporin and even with tacrolimus, people have a incidence of anywhere between 10 to 20% of donor-specific antibodies. And this could account for the improvement in long-term outcome with belatacept, that there is less risk of chronic antibody-mediated rejection. So this is a really, truly very interesting study. When belatacept got approved at Emory, they started putting almost all their patients on Bela, and they used the same protocol as the phase 3. What they found, though, when you use it in all comers, you have very high rejection rate, 50%. Now, these were treated because graft survival at 12 months was 100%. So Dr. Larson at Emory said, well, maybe if I use belatacept and give 3 months of tacrolimus and then I taper it and keep the patient on belatacept, we can get rid of the rejection. Well, that didn't work because there was no rejection in the first 3 months, but after tapering of TAC, rejection increased. So they said, well, maybe we need to keep it for 9 months and then taper. That worked. Rejection rate came down. However, the levels of tacrolimus were a bit high, especially the first 3 months, and patients started getting infections. So what they found that the perfect balance was to keep the high doses of TAC only for 1 month, then lower them quite a bit, and then taper after 9 months. And again, with this approach, their rejection rate was, not 20%, but 12%, and graft survival was 99.5%. But what's interesting, again, is that the DSA levels were lower, and there was a relevant difference in improvement in GFR in the patients on belatacept and tacrolimus. Now, they compared these studies to their historical tacrolimus controls. And so even when you compare it to tacrolimus, belatacept continues to provide all the benefits that I mentioned. Now, Alan Kirk did a small study just showing what can be done basically with belatacept. He used alemtuzumab as induction, belatacept, the same dosage as the phase 3, and then an mTOR, sirolimus. Now, the thing about mTOR and Bela, that there is good basic experimental data suggesting synergies between those two. And then, he added some bone marrow, but I think this didn't do anything. But the long and short is that the rejection rate here was only 12%, and graft survival was 100%. And then around maybe 9 months or so, in many patients, he could wean the sirolimus and keep them basically on monotherapy. And then these patients did quite well and had excellent GFR. Now, at UCSF, after belatacept got approved, I, of course, did not want to use our phase 3 regimen. So we modified it. And what we did, we said, okay, I think we need depletion instead of, in the phase 3, as a reminder, we use the anti-IL-2 receptor antibody So we thought we need actually depletion. So we use thymoglobulin. We call it thymolite because we use 3 milligram per kilo instead of 6, although nowadays we frequently use a total of 6 milligram per kilo. We use steroids, of course, and taper very quickly. Belatacept, the regimen just like in the phase 3. Now, we like to pair belatacept with the mTOR inhibitors. However, to allow the wound to heal, and our surgeons obviously don't want non-healing wound, we wait 4 weeks, and after 4 weeks, when the patient has healed, we convert them to everolimus. So with this regimen, we really had almost no rejection in the patients who were on sirolimus, on everolimus Bella. The only problem is that 35% of patients did not tolerate everolimus, and then we had to convert them to MMF. And in that group, we continued to have a rejection rate in the 20%. So the combination, I think, of mTOR and belatacept is very powerful. It is synergistic, and I think it's an ideal one if the patient tolerates it. Now, the most common reason why patients did not stay on mTOR was they got oral ulcers, and sometimes they are very difficult to eradicate, even if we lower the dose. So this is our conversion protocol. After 6 months, we use whatever was published in those 2 studies. If we convert a patient below 6 months, of course, we keep the CNI for a month. We drop them at 50% after 2 weeks, and then stop them at 4 weeks after we start belatacept. The only difference is that the dose at 28 days, instead of being 5 milligram, as it was used in the 2 conversion trials, we give 1 additional dose of 10 milligram per kilo. And this is a study that we published our initial early conversion, early post-transplant, and these are conversions that we performed if the patient continued to have DGF, did not open up, or they opened up but had suboptimal GFR, well below 30. So in our study, we had 8 patients who converted at 30 days. They had very poor GFR, or they had not opened up. And 12 months later, after conversion, their GFR was 65. So we had another 6 patients that we converted between 31 and 60 days for the same reason. And these patients had a GFR of 52 at 12 months. The one that we converted the latest, between 61 days and 90 days, another 6 patients had a GFR of 39. This suggests that maybe the earlier you convert, the better. Now, many of the patients who have severe, very dense DGF, they don't open up for 90 days. I mean, that becomes primary non-function. And what happens to kidneys that have this prolonged ATN, that they have progressive, very rapid fibrosis? The rejection rate in this group was about 20%. Again, these are, as you see, small numbers, and this is the area, frankly, that requires a very good randomized trial where patients are converted, so that we know what are the benefits, what are the side effects. As I said, one of the patients here had aspergillus because, they get a lot of conventional immunosuppression, and then you add belatacept, and then you convert them to belatacept. So I think there is need for a good study. I was discussing earlier about the lack of biomarkers. There have been several studies. Alan Kirk published a study suggesting that if patients had a high repertoire of CD57, CD4 T cells, these cells are sort of terminally differentiated memory or senescent cells. The belief was that these cells would not be activated, but in fact, these cells don't need costimulation, and they could be the reason why patients have cellular rejection. Other studies have suggested that CD28 negative CD4 or CD8 cells may be involved in rejection. I mean, it sort of makes sense if you are targeting inhibiting CD28 and you have a repertoire. These cells actually start by being CD28 positive, temporal or memory cells, and then they convert to CD28 negative. So it makes sense that if you have a lot of CD28 negative T cells, that those would not respond to co-stimulation. But again, I think we need a really solid study of biomarkers. And if we could predict the 10 or 20% of patients who are resistant to co-stimulation and use co-stimulation super effectively in the other 80%, this is what is precision medicine all about. And I think, that would be how to implement a very good co-stimulation blockade strategy. Now, desensitization, especially in the age of CAS, so a lot of patients who are highly sensitized can get kidneys, but there is one group that is very difficult to transplant, and those patients still amount to the majority. If you look at patients who have a CPRA between 99% and 100, 34% have a CPRA of 99.9 and higher. And these patients get very few kidneys. And these are the patients that do not respond to what people consider standard of care, IVIG, phoresis, Rituxan. And so there are many new drugs now, especially the anti-CD28, daratumumab and isatuximab, that actually target the plasma cells that produce HLA antibodies and the long-lived plasma cells. But it is in combination with belatacept that the best results can be obtained. And this is our ITN-supported trial called the ATTAIN trial. And here we're using basically a theme that was shown to work in non-human primate by Stuart Conneckley. So Stuart Conneckley showed that if you eliminate the plasma cell in non-humanized sensitized primates and you transplant them then with kidneys, the antibodies don't go down, because when you eliminate the plasma cells, there is a compensatory humoral effect whereby the B cells are activated, the germinal center are expanded, and new cells are produced and new antibodies. And what he found out was that the T helper cell, or the T follicular helper cell, gives important signals of activation. So with belatacept, if you block that, then in addition with eliminating plasma cells, then the antibodies production stops, and the new memory B cells and differentiation to plasma cells doesn't occur. And in this study that we're doing called ATTAIN, we're using daratumumab, anti-CD38 monoclonal antibody. We eliminate all plasma cells. We're doing bone marrows, and we show that. At the same time, we give several doses of belatacept, and so we don't have a rebound. And so far, the patients have had a very effective depletion of HLA antibodies, and when transplanted, have not had a rebound and have not had an AMR. So this is actually a study from Emory, where they looked at patients who had, I guess, 100% CPRA, who post-transplant were either on controlled immunosuppression CNI, or they also had belatacept. And when they followed them post-transplant, showed that belatacept was effective in lowering the class 1, but not as well the class 2 antibodies. And when they measured the CPRA post-transplant, those who were on CNI almost invariably stayed at around 100%. But all the patient, the triangles, these are the belatacept-treated patients. As you can see, their CPRA decreased substantially post-transplant. So there is no question that belatacept and co-stimulation blockade plays a significant role in controlling HLA antibodies, and could be a very good adjunct to any strategies to desensitize and possibly to treat AMR in the future. Now, one of the interesting issue with belatacept is that if a patient is on Bela and the patient plans to get pregnant, and so what they should do. And so there are two strategies basically for these patients. One is to stop Bela and MMF and go on TAC and azathioprine, or stop MMF and stay on Bela plus azathioprine. And in these patients, 16 patients got pregnant, remained on belatacept. 3 have miscarriages, the rest had normal pregnancies. One patient lost a kidney because the patient became non-adherent, stopped taking Bela. There was slight decline in 2 patients of GFR. The other ones had remained stable GFR. There were no neonatal death or infant complications observed, and 5 actually patients chose to breastfeed. Now, comparing this to the tacrolimus patients who stayed on tacrolimus during pregnancy, there were 3% have graft loss, and birth defect were in 4%. So basically, it's feasible to, if the patient wishes to stay on belatacept, to manage them that way. So, in discussing with the patient on Bela, there are many hurdles, of course, potentially. One of the things I always do, I ask patients, well, I look at the veins of the patient to make sure that they have good veins. There is no point going through all this and finding there are some patients that have no veins. And then the question is, where can they get the belatacept infusion? We send a lot of our patients to the infusion center, so they don't have to come beyond 3 months to UCSF. Every area has different insurance issues. In our Greater Bay Area, we don't have an issue, but placing patients on belatacept, we have never had any insurance turn us down. But I think the whole team has to be involved, social workers, MPs, and nurses, in being able to effectively place a patient on belatacept and being able to follow the patient after that. Now, in terms of what are the emerging options for co-stimulation blockade, I think there is what I call a renaissance in co-stimulation blockade. Now, on the left side, I want to show you a study that we have completed and not yet published, although it was presented at ATC, where the question was, can we use 2 co-stimulation blockade, belatacept and dazodalibep? Dazodalibep is an anti-CD40 ligand to maintain patients on immunosuppression and after 28 days without any other immunosuppressive agent. So the patients induced with the thymoglobulin, treated 28 days with steroid, and steroids are discontinued, and then the patients get monthly treatments with 2 IV infusions, no oral medications. And in 20 patients, this study enrolled 20 patients. We had 100% patient graft survival. There were 5 patients, 25%, who had reversible acute rejection. But their GFR at 6 months was similar to those who did not reject. And at 12 months, the GFR was 71 ml per minute. So it was a pretty impressive renal function. None of the patients developed DSA. So I think this could serve as a model. I think in the near future, there's going to be subcutaneous formulation of anti-CD40 ligand and also of something like belatacept or an anti-CD28. So I think a simplified intermittent biologic therapy without any oral drugs, no therapeutic drug monitoring is in the future. On the right side, you see one of the study with tegoprubart. Tegoprubart is another anti-CD40 ligand antibody. As I said, there are about 4 of them now that are at some point in clinical trials, either phase 1 and phase 2. So there is a lot of hope that the anti-CD40 ligand will be also effective and potentially synergistic with belatacept. Now, why is there so much interest in anti-CD40 ligand? In 1996, Chris Larson published in the journal Science that if he combined in mice anti-CD28 and anti-CD40 ligand in heart transplant and in skin transplant, he could induce indefinite graft survival. So, and some of this data has been replicated in non-human primates. So finally now we have the ability of being able to combine dual blockade of co-stimulation. So I think it's going to be exciting to see how this can be applied in the future. So basically, to to initiate a discussion with the patient about belatacept. The patient has to know both the benefits and the potential risk. Obviously, the patient has to be EBV positive. In the CMV mismatches, some people use belatacept. At UCSF so far, we have not used it because we are concerned about the potential of having severe CMV disease. I think with the approval of letermovir, that may be a nice option, and I'm sure there's going to be studies to show whether letermovir can be more robust in suppressing CMV infections. So we have two patient cases to demonstrate the outcome of patients that have some challenges with belatacept. So the first one is with pregnancy. This is a 38-year-old woman with end-stage renal disease secondary to IgA nephropathy whose status post second transplant from a living unrelated. The patient had the previous transplant, used to be on CNI, was not happy with CNI. She had with this second transplant, she had a baseline creatinine between 1 and 1.1 and was maintained on a belatacept-based immunosuppressive regimen. She underwent 2 uneventful pregnancy on belatacept, and she was, of course, given the option of going on tacrolimus for the pregnancies. But here you can hear her story in the next video.
Hi, my name is Kristen. I have been a patient with Emory for going on the past 6 years. I came to Emory University for my second kidney transplant. My first kidney transplant I had at MUSC. I've been on dialysis twice, and my primary diagnosis was IgA nephropathy. As I got older, I decided that I would like to have some children. As I approached 40, my doctors kept on asking me, hey, if you're going to have some children, you really need to think about this. I talked to Emory about it. They said, if you want to have children, you need to get off of your CellCept. We'll switch out your medication. And at the time, I was on belatacept. With my first transplant, I was on Prograf, also known as tacromycin. I had a lot of tremors, headaches on tacromycin, and my local nephrologist recommended belatacept to me as an alternative for this second transplant. So when I came to Emory, I asked if I could be switched from Prograf over to belatacept. So Emory agreed that I could be on belatacept since I had already been on Prograf before. And then I decided to approach pregnancy while on belatacept. I switched my medication over, and about 3 or 4 months later, I became pregnant, which was very fast and shocking for me because especially never thinking that I could get pregnant. The 4th month that I was on Imuran, I became pregnant. So here's a picture from my first pregnancy of me getting my belatacept infusion with my first daughter, Leah, which I had no complications with. But to the medication itself, Leah's fine. She didn't have any birth defects. She's developing fine. Then I decided after I had Leah that since I was already on the Imuran, I might as well try to fit in another child so that I could just get however many children I wanted out of the way, and plus I was already getting pretty close to 40. So after that, I got off my birth control for another 2 months, and I was pregnant again. And then here's my picture with my second pregnancy, getting my infusion of belatacept, and also I had no issues while I was on the medication. And so here they are now. Here are my 2 children, my 2 lovely children. I have a 2-year-old and a 5-month-old, so my hands are very, very full. Here's my son, and then here's another picture of him. Belatacept, if they can find another delivery method, I don't have any issues with side effects on it. Just I have to take off the work to go get the infusions, and I have to use the sick time. And with the 2 kids, it definitely can lead me to a time crunch. But I've been having a stable creatinine, 1.0 has been my baseline, and it's stayed at that. And I am 5 months post-pregnancy with my last child. So just belatacept in pregnancy does work. Thank y'all.
So, reported patient outcomes are becoming more and more important. And again, she's sending a strong signal that it would be great. Belatacept really has had benefits for her, but she would love if there was a subcutaneous formulation. So this is a patient two, a 55-year-old African-American admitted for his second deceased donor transplant. His first transplant was complicated by renal vein thrombosis. His CPRA was 74%, group B. The patient got a second transplant. The surgery was uneventful. And then post-transplant, the patient had DGF. 3 weeks after transplantation, he continued to require hemodialysis. Although his urine output had increased, he remained dependent on dialysis. Our protocol says that after 2 weeks, we should biopsy patients to make sure they don't have a underlying rejection. On biopsy, he had widespread epithelial cell injury with identified mitotic figures. The BAM score were 0 across the way. So we clearly thought this is a case of ischemia reperfusion, ATN. We started lowering the dose, hoping to improve the renal function. But at 8 weeks after biopsy, the patient continued to require dialysis. And then at that point, we're looking that if we wait another 4 weeks, that would be 90 days and 3 months, and the patient would be in primary non-function and then have to go back again on the wait list. So at that point, we decided to convert the patient from tacrolimus to Bela, and keeping the patient on lowering dose by 50% after 2 weeks of the conversion and discontinuing it at 28 days post-conversion. Within 3 weeks after the conversion, the serum creatinine decreased, the patient got off dialysis, and then 6 months later, patient had stable function, no DSA. The protocol biopsy at 6 months, we do protocol biopsy at 6 months in everyone, showed a normal kidney with very mild fibrosis, and 2 years after transplant, his serum creatinine was 1.5, eGFR was 56. So this is one clear success. But obviously this doesn't happen in everyone, and that is the need to do a prospective studies in DGF kidneys. So as a final discussion, the issue was how do we define short-term and long-term goals with patients? This is especially critical with belatacept because you see a higher rate of cellular rejection that can be treated, but longer term, patients do better and they feel better. So the issue here, how you balance the two. And clearly in terms of adherence with belatacept, whether the patient adhere or not, whether show up for the infusions. In order to have a successful strategy with costimulation blockade, you need a multidisciplinary approach with people who follow the patient, social worker who can, help in the approval and support the patients, and making sure that in terms of logistics, where they go, what is the closest, for example, infusion center, that they have good access, and that the patient understand, unlike swallowing a pill every day and having therapeutic drug monitoring, that here they have a completely different strategy. They have to go every month and show up and get an infusion. So it's a different way of getting immunosuppression. But I think once they are set in it, most patients continue on it. In all the patients that I put on Bela, frankly, over the years, I don't remember anyone after being on it for a while, deciding not to continue and wanting to go back to tacrolimus. So as one of the final slides, these are the SMART goals, the acronym for specific, measurable, attainable, relevant, timely. Identify situation where costimulation blockade agents may be optimal in conjunction with other treatment for patients requiring immunosuppression post-transplant. Individualized treatment plans and convergent regimens for patients eligible for management with costimulation blockade or who are failing current therapy. and provide customized counsel and support for patients undergoing these changes and emphasis of the long-term goals. So this is to receive the CME credit, as I showed in the previous slide. You have to download the QR and then complete the questions and answers on it. And then the next slide shows how to claim these credits. Yeah, so I'm happy to answer questions either by orally or through the Q&A.
Thank you very much, Dr. Vincenti. I appreciate your coming to talk to us today. I'm sure we learned some things. I actually learned a lot from it. What's your thought, or what do you think about use of belatacept or one of the co-stimulatory agents with some other agents apart from CNI? What do you think the effect will be on post-transplant diabetes?
Oh, well, I think with belatacept, as long as you don't use CNI, there is a decrease in diabetes. We showed that. And of course, the Costimulation blockade doesn't have any additional cardiovascular risk, hyperlipidemia, hypertension. I mean, right now, basically, I think right now, the best combination, as far as I'm concerned, is to use mTOR inhibitors, is to induce a patient with a depleting induction, like thymoglobulin, and then start belatacept. You could start, mTOR right away, or allow 2 to 3 weeks for the wound to heal, and then convert the patient to mTOR inhibitors. At this point, this is your best combination. Again, in the future, we hope to be able to maybe combine dual co-stimulation agents with Bela and maybe anti-CD40 ligand. But this is still experimental and it's not available to anyone. Can you comment if Bela IV dialyzed among patients with DGF? No, Bela is not dialyzed. So it's a big protein, so it doesn't dialyze. If you do plasmapheresis, it will be removed, but not dialysis. Can you comment how important is the CMV mismatch regarding development of rejection among Bela patients? Well, in the phase 3, we didn't necessarily stay away from the mismatches. Now, at our institution, I have preferred to avoid Bela in CMV mismatch, but I don't have data necessarily. The reason why I'm doing that, there was a study in Europe with conversion, and patients who were converted to Bela had severe CMV infection and sometimes resistance and end organ disease. And so that kind of swayed me away from utilizing Bela in the CMV mismatches. I think with letermovir, it may become much safer to do that. I hope we're planning maybe to do a study in CMV mismatch with Bela and using letermovir. So we'll see about that. But I don't have data to say it shouldn't be done. My gut feeling is that it's better not to do it. The next question, can you comment on the development of eosinophilic rejection following Bela administration and their resistance to steroid treatment? I don't know. I'm not aware that there is a eosinophilic type of rejection specifically for Bela. Eosinophils sometimes are seen in CNI rejection. They tend to be maybe more severe cellular rejections. And I mean, usually, if not steroid, but thymoglobulin would reverse rejections. In my experience, I haven't had a rejection, even a severe cellular rejection, that I have not able to reverse, frankly. But there is no question. Sometimes cellular rejection on Bela can be pretty severe, like 2A or 1B. But in general, they tend to be reversible, I would say. And and as demonstrated in several studies where graft loss is very low on belatacept. So, but we have to find ways to minimize the cellular rejection. And as I said, in our hands, at UCSF, when we have a patient that is on belatacept with an mTOR inhibitor, they very rarely have rejection. So that one is a synergistic and very good combination.
Thank you. Any questions in the room? I have a question for you. What's your thought about belatacept in patients with BK?
That's a very good question. So a patient who is on Bela, who develops BK, obviously if they are on MMF, the best thing is to reduce the MMF or the MPA, or maybe discontinue them. But however, one other approach would be to increase the interval of belatacept. So if you have somebody who, you've lowered the MPA, or if they are already on mTOR and they have BK on Bela, the other approach is that you can increase the interval from every 4 weeks to every 6 weeks, and even every 8 weeks. In the phase 2 trial with Bela, there is a group of patients that was treated with belatacept every 8 weeks. And we did some PK and PD showing that you get enough concentration at 2 months to saturate the CD86 ligands that can be, tested. So that I think, you can increase the intervals. And very frequently that will reduce the viral load of BK. So I think if one moves very quickly, first with the MPA or the anti-proliferative, and then increases the intervals, you can control the BK before it gets out of control.
What about patients that were already at the BK and the kidney was struggling? Would you initiate Bela to extend the life of the kidney?
Well,
and how would you initiate it? Would you do the 6 weekly or?
Yeah, well, if they already have, the BK is sort of like a flag that the patient is getting immune incompetent. So personally, if somebody has BK that is not controlled, I would not convert them to Bela.
Okay. Thank you. That's very good. Any questions? Why do you think the results of the first benefit trial did not hold up?
Well, the results hold up pretty well in terms of DSA, GFR, long-term outcome. I think once you have a more diverse patient population with some HLA antibodies, CPRAs, and so on, I think primarily is the fact that the anti-IL-2 receptor antibodies were not good enough when you have a more diverse patient population that are placed on belatacept. But all the other features of the phase 3 have held up pretty well. You don't get DSAs, very few. You get better GFR no matter what, even those who have rejection. And I think longer term you do get better outcomes. But I think the rejections clearly is an issue. And I think that's the reason why you can strategize by using thymoglobulin initially, and then you can, just like as we do, we convert patients to mTOR inhibitors or keep them on MPA. So the other approach, the one that I don't particularly care for, but at Emory have been implemented successfully, is to have them on low-dose tacrolimus for several months. Personally, if I'm going to use belatacept, I'd like to have a pure CNI-free regimen. And at least at our center, it does work. And some of the other people have used the same regimen, have shown it works. So, I think if you look longer term, And beyond the early rejection, risk cellular rejection, I think co-stimulation blockade remains a very good choice for some patients.
Thank you. Any other question? Okay. So it doesn't look like there's any other question. Thank you very much for your time and for a very educational session. I definitely learned a lot from this, and I'm sure the rest of the team too did. One of the things that's very that I learned particularly and may help us change practice or look into it more is use of belatacept in highly sensitized patients. It's one of the places where we are more cautious because we feel they're sensitized and we try not to get them off CNI. So thank you very much for a very informative session, and thanks for joining us.
Well, my pleasure, and thank you all for listening to my presentation. Thank you. Have a good day.